Let's talk about the last condition within the nervous system, which was the tuberous sclerosis. Let's break down the term. The tuber and sclerosis, which means hardening, and tuber means swelling or growth. So in simple word, all those swellings which are hard in nature. So this makes up the tuberous sclerosis. Now this is also called as bone will disease. Bone will disease. It is again an autosomal dominant condition, and the pattern is autosomal dominant inheritance pattern, and the occurrence is 1 in about 8,000. This is average. It can range from about 1,000, 1 in about 6,000 to about 1 in 10,000. Anyways, now because we just said there is swelling, so there is again benign growths. Okay, benign growth, so it is non-cancerous in nature. Now usually it is categorized in nervous system, but tuberous sclerosis is a multi-system affecting condition, multi-system affecting disease. I'll not say disease, a multi-system affecting disorder. Before jumping onto the system, let's quickly discuss about its genetics. So it is again of two different types, TSC1 and TSC2. TSC1 and TSC2. TSC simply means tuberous sclerosis complex. So tuberous sclerosis complex, TSC. Now TSC1 is much more common, and about 85% of the cases are TSC1. Next is TSC2, and the TSC2 is much more severe in case than the TSC1. Now let's talk about the chromosome. So the chromosome involved in TSC1 is 9, chromosome 9, and for the TSC2 it is chromosome number 16. Okay, done with this. Now let's talk about the protein they form. Now the TSC1 forms the hamartin, and TSC2 forms the, for 2 it is tuberin. Okay, pretty easy to remember, hamartin and tuberin. Now these are again found on, so we just said that it is on chromosome number 9, so CHR9, and this was on chromosome number 16, so CHR16. Now which part, which segment of the chromosome it is? So 9q34 and 16p13. It is optional to remember this. Okay, not that much important, but at least you should remember the chromosome number and the protein. Okay, and which is much more common and much more severe. So all this, at least this thing up to here, is high yield. Remember this one. Okay, now next point to remember is this: hamartin and tuberin actually act as tumor suppressor proteins. So tumor suppressor protein, when they become malfunction, as in the case of tuberous sclerosis, so there will be uncontrollable growth, which is termed as tumors, and these tumors will be seen all around the body, but much more particularly in CNS or the nervous system. Now, this tumor is due to again high-yield mTOR pathway dysregulation. Now, what this pathway is, again, not so much important. Just remember it is mTOR because the drugs which we'll focus on will be focusing more on targeting this mTOR. So again, important. Now, let's quickly discuss the different types of condition it can cause. So first of all, it can cause hypopigmentation, hypopigmented leaf shaped macules, or okay, let's complete it over here. Macule. So it is again a dermatological condition. Next is cortical or subcortical tubers or swelling within the brain. Next is astrocytoma. Astrocytoma again in brain. Then there is SEN, subependymal nodules, very very important. Okay, at least remember this and this. Subependymal nodules. Now again, these nodules can be again calcified, so there can be calcification in it, and these SEN can combine with the astrocytoma, or we can simply say that these astrocytoma along with SEN is called as SEGA. SEGA. SEGA means subependymal giant cell astrocytoma. So as the name suggests, it is in subependymal cells, giant cells involved, and astrocytoma is also involved. So SEGA, very very important feature. Okay, we are done with this. Now, next point is large cortical hematomas can be there. Large cortical tuber or large cortical hematomas, both in cortical or in subcortical regions can be seen. Hematomas. Okay, done. Now, all the clinical features will be depending upon in which location these tubers are. Okay, so the clinical feature will depend. Okay, there is no space. Clinical feature depends on location. On location of these tumors. Okay, let's say these tumors are in CNS. Okay, in CNS tumors there was cortical and subcortical tubers, astrocytomas, SEN, both calcified or SEGA, doesn't matter, large cortical hematomas, and so and so. So whenever it will be within the CNS, it will occupy some space. It will increase the ICP. Okay, it can again cause different other manifestations such as autism, depression, ADHD. IQ can be hampered. So autism, ADHDs, decreased IQ, epilepsy, seizures can also be there, epilepsy, etc. Depression and so and so. So all the different types of it can also compress some nerves. So neurological manifestations will be such. Neurological manifestation, limb weakness, ketosis, and etc. Okay, you know all these things. Neurological manifestations. Good. Now we are done with the increased ICPs. Now next is let's say lungs are involved. Okay, there is a very peculiar condition, important condition of LLM, or sometimes referred as LAM. Okay, it means that lymph angio, lymphatic system, blood vessel system, leiomyomatosis. Okay, so three structures involve: lymph vessels, lymph blood vessels, plus muscles. Okay, so there is, because it is an oma, right? So there is abnormal growth of smooth muscle and lymphatics within the lung parenchyma. Okay, and the manifestations, clinical features, will be because of this. Okay, so they will be shortness of breath, dizziness, fatigue. They can be hemoptysis. They can be also wheeze. Okay, they can be again dry cough, etc. along with it. Okay, and also this tumor will be estrogen dependent. So because it is like this, so it will affect most commonly a female, that too of a reproductive age. So age will be about 15 to 49, and more particularly during pregnancy it will be even much more severe. Okay, so LAM is a condition again within the tuberous sclerosis, affecting primarily the females, along with the symptoms of these. Okay, just remember. Now it can affect eye. It can cause again retinal, nodular hematomas. Then they can be again a characteristic feature of skin, along with this leaf-shaped macule, this one. So within the derma, within the skin, there will be adenoma sebaceum. It is a type of again angiofibroma. It is a very important feature, and I'll talk about it, how it looks like. I'll show you the picture. A very strange, dirty type of picture it is. But again, next is for heart. In heart again, it can cause and form some nodules, which is a rhabdomyoma. For kidneys, for the kidneys, it can cause angiomyolipomas. And for one more thing, there will be a shagreen patch. Then there can be also again ungual fibroma. So as you can notice that there is everywhere this oma. Okay, there's everywhere it's like a tuber or swelling or all around the body. Now, and within the skin again, they can be ash leaf spots can be seen. These are again ash leaves. Okay, so these were called as ash leaf spots. Okay, ash leaf spots. Ash leaf spots. Fine. Now, I guess it is everything. Now, let's check for the next page. Now, the manifestations of all these structure will give off some sort of clinical feature. For example, in the case of heart, they will be rhabdomyoma. They can be also arrhythmias along with it, arrhythmia, which will lead to again heart failure. The angiomyolipoma again will lead to hematuria. There can be again hypertension because of it, hypertension, and there can be again renal failure. Now, as we were talking about the adenoma sebaceum, there will be a child or a middle-aged person, okay, and there will be very dirty growth. Let's say this is a nose, and then there will be, in the initial phase it will look like a freckle, but again it will keep on growing all around the nasal part. Okay, it will keep increasing in size. Okay, then it will be like this. So this is again and particularly it is yellowish in color, but again it can have pinkish and reddish appearance also. It will be again multiple in number, so multiple small papules will be seen. Let's see if I have an image of it. Let me check. Do we have an image? So this is an image of early presentation where these small nodules are present all along the nasolabial region. So all the nasal crease, nasal folds are involved in it, and there are small papules. Okay, next picture. In the severe case, this is a severe condition of the adenoma sebaceum. See how big it is. In the early presentation, these are yellowish, then again it keep on changing the color, which can range from reddish to pinkish to brownish. Okay, and in the other picture it is somewhat purplish in color because it is a type of angioma. Okay, we are done with this one. Just a moment. Now, let's talk about its pathology. Okay, let's talk about its pathology. Now, we discussed that there were genes. Okay, these were two genes, TSC1 and TSC2, which was giving us of hamartin and tuberin. Okay, so there is hamartin and tuberin, and these are proteins which are acting as tumor suppressor proteins. Okay, and this actually inhibits RHEB, the function of hamartin and tuberin is to inhibit RHEB. What is RHEB? RHEB is RAS homolog enriched brain. enriched in brain. If you can remember what is RHAB, it is fine. If you can't, that's also fine. Okay, just remember that once RHEB is inhibited, it will increase the mTOR pathway. Okay, so this increase. So the function of RHEB is to increase the mTOR pathway, which will cause and control the cell size, the cell growth, and neuronal differentiation. So the problem with hamartin and tuberin will directly affect these. Either their overexpression, underexpression will cause this. Okay, we are done with the patho and mechanism of formation of tubers. This will lead to tuber, and tuber also with the hardening. Okay, benign tumors. Okay, we are done with this one. Now let's see how to diagnose it. In diagnosis, we can go with the ultrasound. We can also use MRI, CT, all the different types of imaging of head, and particularly USG for your heart. CT can be done again for the head, and again of CT and MRI both for lungs to rule out LAM or LLM, whatever, whichever you like the most. Okay, now what we can suspect in the USG. For this one, we can suspect rhabdomyoma, which are again as a nodule attached to the wall of the heart. Okay, let's say this is your heart, this is your chambers. So these will be the extensions like this. However, there may or may not be connecting structure, as in the case of atrial myxomas. So there can be a differential diagnosis of atrial myxoma in this case. So better we rule out this. Let's see if I have an image for this one. Do I have? I guess no, I don't. Anyways, so yeah, next we can go with the LAM presentation. Now LAM/LLM. For the LAM and LLM, what we can suspect? We can suspect this. Let's see the picture. Where is it? Okay. You can see this. So again, these are multiple, really so much. Many cysts. See, all the lung is again filled with multiple cysts. multiple cysts can be visualized, and in the T2 weighted imaging, all of them will look like a mass. Okay, this is how we can check for the LLM, and also again the family history and other things. Family history presentations, onset, so and so will also help us to make a diagnosis of LAM and LLM. Good. Now, let's check for other different types of growth. So, yeah, this one. Previously, we discussed that there will be a growth which is called as sega. So, this is a sega along the ependymal lining of the ventricles. Okay, this is a sega. This can even become so much big. Okay, let's show you the picture of a huge sega. Now this is a big sega, and because of this it will also lead to obstructive hydrocephalus. There will be headaches and other neurological manifestations we can suspect because of this obstruction. So this is a huge sega. We're done with this one. Great. Next. Now, these are the two pictures I have. These are your subependymal tumors, T1 and T2 images. Okay, now these are your subependymal nodules. These, see these small ones, these small tumors over here, here. Okay, these all are your subependymal tumors. Okay, next, what else we got? Okay, we're left with these two. So we just talked about subependymal nodules. Now these are your cortical, subcortical tubers or swellings. Okay, these, okay. So these are your cortical and subcortical tubers. Depending upon the location, it can be toward the cortex or it can be toward the subcortex within the brain. Okay, and for the clinical features, again, mass or occupying a lesion, it can compress the nose. There will be neurological symptoms, headache. There can be psychotic conditions. We are familiar with all those things. Okay, so whenever we suspect, we go with the CT and MRI of the brain. Now, what are we left with? Okay, very important one, very important picture. Okay, so first picture, you see these leaf-like structures, leaf-like hypopigmented structure. These are your leaf-like hypopigmented structure. Which is also called as ash leaf spots. Classical feature. Next is these. Can you see these? On the first glance it looked like um what's the condition in Hindi we call it as pitti. Anyways, I just forgot the name. So it's a fluid filled condition during the allergy. And these, oh, so for the second one, it is called as Chagrin's patch. It is called as Chagrin's patch. So for the chagrin patch, how it looks like, it is rough, kind of reddish, it is a rough, reddish, irregular, raised. Okay, let's write it like this: red, rough, raised, and irregular in nature. Okay, and lastly we have these growths, see, and then there is small over here. Anyways, these are called as angual. Angual is a term for your fingernails. Angual fibromas, angual fibroma. These are your characteristic finding which one should know. Okay, and yeah, this is again the most severe form of angual fibroma. Severe form of angual fibroma. Hope you can mark it. These again, see, everywhere. In every finger there is. These are your severe form of angual fibromas. Fine. Now there is very important thing. There is a criteria for diagnosing tuberous sclerosis. Tuberous sclerosis. Let's see the criteria. So at least there will be one major criteria and two minor criteria. There should be present in order to diagnose it as TS. Okay, so let's divide major and minor criteria. Minor and major. Okay, so there is a list. At least one of them should be present. So cortical, subcortical tubers, swellings, subependymal nodules, sega can be there. There can be angiomas on face, facial angiofibroma, angiofibroma, at least more than or equals to 3 should be there. Then angual fibroma, again more than equals to 2. I don't remember these. Okay, if you can remember, fine. If you can't, that's also fine. Just remember there should be all these. Okay, next is hypopigmented macules, also called as ash leaf spots. Good. Hypopigmented macules. It should be at least more than equals to 5 millimeter in diameter, okay, and at least more than equals to 3 places. Then there can be a shagreen patch. How a shagreen patch looks like? This one. Now there can be multiple retinal nodular hematomas. Then there can be cardiac rhabdomyoma, which is again a nodular structure onto the wall of a heart, rhabdomyoma. Then there can be renal angiomyolipoma. There can be pulmonary LLM or LAM. Okay. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Out of 11, at least one should be there. And for the minor, there can be small things. Dental impairment can be there. Dental enamel pits. Dental enamel pits within the tooth. There can be a pit formation. Okay. 1. 2 is intraoral fibrosis because of this hardening. Then there can be a retinal achromic patch, retinal achromic patch. 4th will be confetti lesions. Just remember the names. Okay, confetti lesions, non-renal hematomas. List is huge, I know, but what can we do? Multiple renal cyst can be there. Okay, so 1, 2, 3, 4, 5, 6. Total 17. And out of 17, at least 3 in the form of 1 major and 1 minor should be there to fulfill the criteria in order to diagnose this condition. I guess we have one more picture. Okay, I just forgot to show this one. Now this, see, one fibroma over here, then over here. These are your however in this case it is solitary, but it can be again multiple in nature, multiple retinal hematomas. Good. Now how to treat it? Again, because being autosomal dominant and DNA is affected, chromosomes are affected, so there is no treatment. Okay, we can just simply make the life easier by giving some drugs. So there is also one mTOR inhibitor. Okay, so we just discussed that because of overactivation of mTOR, there was all this cell size increase, cell growth, neuronal differentiation, right? So if we inhibit this mTOR, we can pretty much try to control at least new formation of these growths. So two major drugs, which are everolimus or sirolimus. So limus, remember this one. This is particularly for uh, for your tuber control, for tuber control, in particular new tuber controls. And secondly is symptomatic managements. So we discussed all different types of other manifestations which can be present in this case. So we can go with the symptomatic management to give the relief to the patient. Relief to patient. And if needed, surgery can be an option. Surgery can be an option both for a cosmetic point of view and for clinical and medicine point of view. We can go with this surgical point of surgery for the patient to remove the excess tuber. Okay, I guess we have completed everything. We have not left with any important points. Okay, so over here these were the growths, these, and these. Sega is done. I guess we have done with pretty much everything. Okay, so we are done with tuberous sclerosis. We are done with the nervous system now. Okay, in the next video we'll discuss different types of case study. I'll get some MCQs for you guys. Don't worry, there will be 4 options of Huntington's, NF, MD and TS. Let's get a hold on to this, on these 4 topics. Okay, thank you for watching. See you in the next video.